Hi everyone, this is Divya from Quickmommyhacks, and today we wanted to talk about gestational diabetes and pregnancy. And for this, I have an exceptional endocrinologist with us. Her name is Dr. Meena Murthy. So, Dr. Meena Murthy is the chief of the Division of Endocrinology, Nutrition and Metabolism at St. Peter's University Hospital. She is also the director of St. Peter's Thyroid and Diabetes Center and director of SKN South Asian Diabetes Center and South Asian Institute at the Department of Medicine. She's an exceptional endocrinologist and is also an educator with over 42 years of experience in the medical field. Hi, Dr. Murthy, how are you? Thank you so much for being here to talk about gestational diabetes today. So, I guess my first question about gestational diabetes is what exactly is gestational diabetes?
When we say gestational diabetes, it's diabetes that started because of the pregnancy or from the pregnancy. And so that usually starts in second trimester, maybe around 24 to 28 weeks generally, because by then the placenta has grown. In first trimester we don't have that. So at that time, the increased demands for insulin, because of the placental hormones and so on. If we already have insulin resistance or decreased capacity to make insulin, we'll develop diabetes at that time. But technically, any high blood sugar first time diagnosed during pregnancy, we would probably just term it as gestational diabetes.
So, usually regarding the screening test for gestational diabetes, as you mentioned, it's towards the second trimester. So, what should we expect from the screening test of gestational diabetes?
So, what we have to remember is when we say screening, it is screening of general population where we expect the prevalence of the problem to be very low, right? So, it is not for high risk or at risk individuals, right? So this is if you take everyone who is pregnant ever and you test them, the yield is highest. We don't want to do tests when we're not going to find a positive. So the yield is highest between that 24 and 28 weeks, meaning it's not too late, it's not too early. So people do get screened at that time with a glucose tolerance test. But if they already have impaired fasting glucose and all that, that itself, may tell us something. But we have to remember a lot of people we see, especially certain ethnic backgrounds, like Asians and Latinos and so on, will have high risk prior to pregnancy or early in pregnancy. They need to be screened much earlier, even prior conception.
So, is it like can it happen in third trimester as well?
Sure, it's a continuum of a process. So just because our test was negative does not mean we are at risk. We are not at risk, or we will never get it, right? So as pregnancy progresses, so certain time where we are concerned that someone, is at high risk, even though their 26-week just glucose tolerance test seem normal, we may say, I'm concerned. So as a physician, I would say, I'm still concerned that you may develop it, so you should repeat it when you're 30 weeks or 32 weeks or whatever. But that's not the common standard in many obstetrical practices. Let's say someone gained 10 pounds between 26 and 30 weeks. Okay, so now they were not, showing any abnormalities at 26 weeks, but now they will, because that extra 10 pounds added additional risk, right? So we need to make sure that it is individualized. So generalized recommendation for screening should not be applied as is to an individual. So we need to look at the context. As physicians, we need to look at the risk status. But that doesn't always happen in a physician's office, I would be the first to admit, because it becomes a mechanical process. Most of the people I see did not come to diagnosis early enough.
Okay.
Or their risk factors were not managed prior to pregnancy. And that is sad because this is completely preventable.
Do you think that gestational diabetes runs in families, and what kind of women, group of women are more susceptible to it?
Okay, so as far as risk factors for gestational diabetes, yes, if you have family history of gestational diabetes, or if you yourself had gestational diabetes in prior pregnancies, you're definitely at risk. Okay. Women who are overweight, women who are obese, women who have menstrual problems, fertility problems, polycystic ovarian syndrome, women with issues with lack of fitness, and certain ethnic backgrounds, right? Like, for example, Asians are at very high risk for gestational diabetes. If a pregnant woman or a woman who is conceiving at the time of conception or any time after, if they have high blood sugar and sustain that high blood sugar, that passes on to the baby. Okay. Meaning, when we are pregnant, we make a lot of changes in the baby's body. We call it developmental programming. So in last 40 years, 40 years ago, we knew in rats that diabetes can pass on from generation to generation just by mother rat having high blood sugar during pregnancy, right? Not only that you're going to have problems for the mother, problem for the baby, but you're going to pass on this abnormality of developing obesity and diabetes to the next generation and to the next generation and to the next generation. So in last 30 years, the obesity and diabetes rates have gone up tremendously because a lot of mothers have hyperglycemia or high blood sugars during pregnancy. So if somebody's blood sugar, fasting blood sugar is 90 versus 95, you already have a large baby. Yeah. 5-point difference. You already have a large baby, and that large baby is prone to have diabetes earlier and will pass on to the next generation. So, and each generation it gets worse.
Are there like long-lasting effect of gestational diabetes if the mom had gestational diabetes during the pregnancy?
The mother, needs to be tested to see if it was gestational diabetes or there is persistent diabetes. So we may have misdiagnosed type 2 diabetes during pregnancy as gestational diabetes, like I told you, which happens many times because they were not screened in the preconception time. They were not screened in the first trimester. So we missed it. And we diagnosed it in second trimester and called it gestational diabetes, but it was actually type 2 diabetes that the woman had. So we check postpartum. Normally, if it's true gestational diabetes, it should go away after the baby is born, right? So a lot of women test negative, right? So at 6 weeks or 12 weeks, if we do postpartum glucose tolerance test, a lot of women will look normal on their testing, but their risk has not gone for diabetes, right? So they will, develop diabetes in the next pregnancy, or they may develop diabetes in between pregnancy, and more than 60% of them will develop diabetes down the road. So diabetes is a major risk for them. So everybody breathes a sigh when their glucose tolerance test is normal after their childbirth. I would say no, you cannot do that. You really need to take this as an alert as a warning signal, and you want to work on prevention of diabetes or management of diabetes. So if you find diabetes at that time, you really want to work on it intensively to control it and reverse it. But if you are normal on the testing, you still are at risk. What can you expect in the baby? Now, again, we are talking about postpartum. If the baby immediately at birth, we have to differentiate gestational diabetes from diabetes during pregnancy. So I'm now talking about gestational diabetes, which started for the first time in second trimester. So those babies don't have a lot of congenital abnormalities like the babies born to a mother with diabetes. But nevertheless, the organ maturation is slow, but the baby is big. So the baby will have birth trauma. Mother will also have delivery issues, right? End up with a C-section unnecessarily many times. But the baby, the large baby, may have low blood sugar, low calcium, low other things, and end up being in the neonatal intensive care to be managed. So we worry about stillbirths or premature births or birth issues. But afterwards, generally, I'm talking about uncontrolled gestational diabetes. This should not happen to mothers where we manage the gestational diabetes well, right? So I don't want everybody, just because they have a label of gestational diabetes, they're not going to have complications. If it's not diagnosed or not managed well, then only we have problem, right? And that baby is prone, as I said before, for being overweight, for being diabetic much earlier.
So how do you usually manage gestational diabetes, and what is the course of treatment?
Most women don't need any medications, right? If we manage it right. So we will change how they eat carbohydrates. We are not restricting calories during pregnancy unless they were already over consuming it. But we are, the problem is their response of insulin, to the carbohydrate load, meaning the starch, how much they eat and how their insulin works for it. So we will distribute the carbohydrates. We will ask them to eat only certain grams of carbohydrates per meal. So they have to learn carbohydrate counting. They have to learn physical activity post meals. So meal-related activity will help reduce post-meal blood sugar. So some women, their post-meal blood sugars are normal, but fasting blood sugars are high. So that's managed a little bit differently. If we are using medications, no matter that people want oral pills, insulin is the best agent, and that has been, well studied. Because insulin does not, go to the baby, whereas the medications do cross the placental barrier and affect the baby.
So do all the gestational diabetes pregnancies, do they result in C-section, or do they have, all of them have complications?
So as far as C-sections, there is high rate of C-sections in mothers with gestational diabetes. So because they have many times other problems like preeclampsia or other complications in the late pregnancy. Or that the provider is just worried about this and they just want to deliver the baby safely. So for one reason or another, whether it is indicated or not, there is, if you look at the statistics, whether in, any region, there is high level of C-section. None of our patients should develop complications, right? That tells how we managed it and how they cooperated with us, right? So if we make early diagnosis, meaning we know the risk factors, we make early diagnosis, we manage it well, they should have zero complications. We have more problems in those, mothers and babies if there was diabetes in the first trimester and that was not diagnosed. So there are more congenital malformations.
Like, what can you do beforehand in order to lower your risk?
It has to start preconception, before planning pregnancy. Before pregnancy, doing these tests to make sure, like whether it is A1C is a minimum testing for diabetes, but that may not pick up. So glucose tolerance test, because we are trying to be more precise. During pregnancy, people don't know how much weight they should gain. They overestimate the amount of weight gain, or they were not paying attention. Meaning, if you were obese prior to pregnancy, how much weight should you gain? If you were underweight during pregnancy, how much weight should you gain? When you just read somewhere or your family member says, I think it's about 25 pounds, you don't know that if that is right for you. That is one way to prevent diabetes. Because rapidly in the first, a lot of people may lose some weight during first trimester, but they start gaining a lot of weight very rapidly in the second trimester. And by the time they know it, they've gained 20, 30 pounds, right? It's a problem. So many women are gaining 40 to 60 pounds during their first pregnancy. And that is very, very high risk. So that's how you can prevent. Are you in good fitness? Are you exercising? Because again, we ask women whether they were fit and they were exercising. Yes. Are you exercising? No, they had stopped exercising when they started planning pregnancy because they think exercise is bad for their pregnancy. There is no basis for that. You can modify the exercise, but you don't have to stop activity, right? So being very sedentary is a problem. And also, pregnancy is an insulin resistant state, and body physiology and hormonal physiology changes a lot. And so women have hunger or sense of hunger, I would say, or cravings, whatever they may call it. And they start eating things that they never ate before, whether it's sweets or meats and other things. And that is a problem. And people loving them and they thinking they need too much, right? Because there's all kind of mythology about how much a woman should eat, right? So parents and friends, trying to feed them is a major problem.
What kind of advice would you give to women who have gestational diabetes in order for them to actually have a healthy pregnancy throughout and a healthy delivery?
It is very important to still maintain visits with your physicians, with your nurses, with your educators, with your fitness gurus, coaches, whoever, right? Going to the gym is a problem, but you can walk in a park. You can walk in the house. There are all kinds of videos available or trainers available to teach what you have to do. Dietitians can do, your nutritionist can do, carbohydrate counting, teaching. You can also learn from, of course, internet sites and so on. But anything you learn generally, you should verify it with your own doctor who is caring for you to make sure that applies to you.
And thank you so much for answering all the questions and clearing our doubts about it. And I'm sure women would find it useful. So thank you.
If you like our videos, do subscribe to our YouTube channel, Quick Mommy Hacks, and follow us on Instagram for some personal tips on pregnancy, childbirth, and motherhood. And do leave your feedback and comments. We would love to hear from you.